Hello everyone. Today I just thought we go through kind of the skills of history taking. I know when people come to the department, they get the templates on how to take an obstetric history, but they don't get the gist of what we are exactly trying to do. So I'll just quickly take us through that. The first thing is realizing how important taking a good history is. Um, I must say that the best way to learn how to take a history is, of course, just to take a history, talk to a patient. That's the best way, but we have to get these basics before we go in. So the first thing about history is that you're really building a connection with the patient, especially in the department of obstetrics and gynecology. People might be telling you things they don't tell everyone out there, things that are personal, things that are private, and so on. So you need to build some connection, some trust with the patient so that they can get this information to you. The other thing we need to realize is that then the way you carry yourself, the way you are dressed, your hair, the way you introduce yourself has an implication on how much the patient will tell you, the privacy where you are sitting, the confidence the patient has in you that whatever you tell them is not going to be publicized out there. All those things have an influence on what kind, the quality of information that you are going to get from the patient. Having said that, what do you really want to get in the history? You want to get what caused the disease that the patient has, because the first thing that is important in the history is the complaint that the patient has. So you want to make sure that you really focus on the complaint, because the complaint is what brought the patient to the hospital. So we'll talk about the complaint much later, but the important thing now is realizing that the complaint is where you start building what caused the disease. So you need the history needs to help you decide what caused the disease. It needs to help you find out what are the risk factors for that disease. What are the things that has made this patient get this condition? For instance, a patient has a miscarriage. They want to know, why are they the ones getting a miscarriage? You have a diagnosis. The diagnosis is that this patient has an incomplete miscarriage or has a threatened miscarriage. What the patient wants to know is, why are they the ones with a threatened miscarriage? Why isn't it their neighbor, for instance? Why is their neighbor okay and they are the ones with the disease? That's what risk factors is. So you need to dig, because this is important for the patient, because they want to know that they didn't do anything wrong to get the disease. So you want to dig into the risk factors, and then you want to figure out, whatever disease, what complications has it led to. So if we are talking about an incomplete abortion, has it led to anemia, for instance? Has it led to depression in the patient? Because all those things will affect how you are going to treat this patient. So your treatment is being decided by the kind of information that you are getting from the history. You are getting the kinds of drugs the patient is on, the kind of person they are, do they easily take tablets? All those things will determine the kind of treatment. So you are getting all this information for all these things. So you are trying to make a connection with the patient. You are trying to know what caused the disease. You want to know the complications of that disease. You want to know the risk factors for that disease. And as you get the information, you want to know, how will I help this patient and treat them? So before you go into the history proper, you have to get the demographic information from the patient. You need to get what is their name, what is the date that you're taking the history, what is the time, who is giving you that information, who is the informant. Sometimes the patient comes with eclampsia, they've been convulsing and they cannot give you a history. They come in coma, they cannot give you a history. So you get a history from someone, you need to indicate whose history that is, and sometimes and many times these days you have to indicate the phone number for the relative that the patient has come with, and the phone number for the patient. Then you, the history taker yourself, has to have your name on the file as well. Then you need to get the occupation of the patient. The occupation might be related to the problem that the patient has come with. Where do they actually stay? This might be linked to their socioeconomic status. Where do they go? What is their nearest clinic? Is it that gives you an idea of how easy maybe follow-up will be, and who has really referred them, what kind of facility it is. And you also need to get information about their religion. If somebody is a Jehovah's Witness, for instance, they might refuse to get blood. If somebody is a Catholic, they might refuse to get contraception. All those things might affect the way that you are going to care for them, or help you design a way that is friendly for them to be taken care of, or develop even a language to speak to these patients. And then also we normally indicate their relationship status. Are they married? Are they single? And so on, because this is important information for diagnosis, to build trust, and also to just get to know the patient who's in front of you. Yeah, so when you take an obstetric history, you need to get the preliminary information. So you want to know the gravidity of the patient, which is how many pregnancies the patient has had, the parity, how many pregnancies they've had that have crossed the age of fetal viability, what is their gestation age, that is what is the size of their pregnancy. You want to get the presenting complaint. The presenting complaint, as I've already said, is very important, because that's what made the patient move from where they are to where you are. Without the complaint, you wouldn't have seen that patient. So it's very important not to disregard the complaint. Many times when we are taking a history, we kind of lost in knowing the diagnosis, very complicated words, trying to assign the disease to the patient. As much as that is important, we need to remember that the complaint is the most important thing. We need to have a very clear reason why the patient has come to the hospital. Because if that issue, the reason the patient has come to the hospital, is not sorted out, even if we know the diagnosis, then that is not of value to the patient. So when we get a history, we want to know, why did this patient walk from home to this place? Then once we have the complaint, we have to expand on the complaint, which is what is called the history of the presenting complaint. So when somebody comes with a complaint, for instance, that they are bleeding and they are pregnant, maybe they are 20 weeks pregnant, or they are 28 weeks pregnant and they are bleeding, what you are trying to do in the history of the presenting complaint is to ask all the questions that are related to vaginal bleeding in pregnancy in somebody who's 20 weeks pregnant. So all those questions you're asking in the history of presenting complaint are trying to lead you to the reason this patient is bleeding, trying to lead you to the diagnosis. So they're bleeding at 28 weeks. Do they have a coagulopathy? So you ask questions that will help you decide if it's a coagulopathy they have. You ask questions that will make you think, do they have abruptio placenta? You ask questions that will make you think, do they have a placenta previa? You need to ask questions that will make you think, did they have trauma? Was this patient attacked? Was she kicked in the tummy? So the history of presenting complaint kind of is limited really by the knowledge that the one who's asking the questions in this area is, because a patient can bleed for so many reasons. They might have cervical cancer, so you need to ask questions that are related to cervical cancer. They might have vasa previa. So you need to ask questions that are related to vasa previa to know why this patient is bleeding. They might have an infection, a cervicitis, for instance. They might have a polyp. That's why they're bleeding in pregnancies. So all these possibilities, you ask for them in the history of presenting complaint to try and decipher what is the cause of this bleeding. Even the drug history as a part. Maybe somebody is on an anticoagulant, they are on warfarin, they are on aspirin, that's why they are bleeding. They are on heparin, that's why they are bleeding. So all that is related to the kind of drug history that you are going to ask. So all this history of presenting complaint is you putting together all the possibilities that can cause that complaint, and you put them together. So you ask all questions in all areas that explain the reason that the patient might be bleeding, so that at the end of the history of presenting complaint, you really have an idea about why this patient who's at 28 weeks gestation age is bleeding. So from the history of the presenting complaint, then you go to the systemic review. So you are reviewing all the system. We know that the human body has several systems. You have a genitourinary system, you have a gastrointestinal system, you have a cardiovascular system, we have central nervous system. So you ask, you go through the systemic review, and the idea of the systemic review is really just to counter check that you haven't missed anything. There are things that the patient don't say, but they have complaints in those systems. Sometimes the patient doesn't know that their complaint, the fact that they are passing urine that is bloody, the fact that they are passing stool that is bloody, is related to the fact that they have vaginal bleeding. So they might miss out those things. So you are doing a systemic review to pick out what you've missed, and also to pick out what the patient has missed, so that you put all the information together. So any system that has not been tackled in the history of presenting complaint is now tackled in the systemic review. Musculoskeletal system, for somebody who's bleeding vaginally, maybe you can ask, do you have any swelling of the joints? Do you have any bleeding in the joints? Because if somebody has a coagulopathy, they might be bleeding in the joints. So the systemic review puts together everything that the patient has forgotten in the other system that they think was irrelevant, and also if you missed out anything in your history of presenting complaint, the systemic review puts everything together. So after we've done a systemic review, we need to move to the history of the present pregnancy. So the patient is pregnant now, so we need to go into the history of the present pregnancy. So we look at the menstrual history. When was their last normal menstrual period? Was the last period they had normal? How many days did it last? Are their periods regular? So all this information helps us decide if we can depend on the history to determine the estimated date of delivery, or we can depend on that history to calculate the gestation age. How sure are they about the last normal menstrual period dates? Because we are going to use Niggle's rule to calculate the estimated date of delivery. So it's important to make sure that we have the dates that are correct, the regularity of their periods. We also want to know if they were on contraception, the time they became pregnant, because all this has an influence on the accuracy of the dates that we have. Then after taking a menstrual history, we have to take what is called a booking history. So a booking history is when did they book, when did they go for the first time for an antenatal visit, where did they do that booking, how was their pregnancy confirmed, did they do a pregnancy test, did they do a scan on their booking visits, did they do any any other tests. This is also the kind of history you are getting in the antenatal history. So all this information is there about what they did in the antenatal period, what has been happening, have they gotten folic acid, have they gotten Fansidar, have they gotten tetanus injections, everything that was done, have they been dewormed, everything that was done in the antenatal period thus far should be recorded in the antenatal history. Then we move on to the history of the previous pregnancies. So if this is the first pregnancy, it means that we skip this this part. If the mother or the patient in front of us has had 3 pregnancies, then we go through all the pregnancies. So we go through the first pregnancy. When did they deliver? How did they deliver? Did they have a C-section? How did the pregnancy go? Is the child still alive? If they had a miscarriage, any miscarriages, we do history of any past pregnancies that this patient had, regardless of outcomes. So we put them chronologically from the first one to the last one, and then we've already, of course, taken the history of the present pregnancy already. So this is important because it tells us how this patient has gone through many pregnancies, and if the pregnancies have gone well without any problem, it's very likely that we are probably not going to have any problems in this pregnancy as well. So then we look at the gynecological history as the next thing. So that is, have they had any cervical cancer screening? Have they had any gynecological problems, any gynecological surgeries, any ectopic pregnancies? Here we can also get a contraception story if it's there. Sometimes people put the menstrual history there, but we've already dealt with it in the history of the present pregnancy in this case. Then we go through what is called the medical history. Usually people here ask any medical disorders. We need to remember that we need to connect the presenting complaint to what we're asking. We can't ask about all possible diseases that a patient has had before or like that. We need to connect the complaint to the medical history. So, but people generally ask the common conditions. Have you had do you have diabetes? Do you have asthma? Do you have epilepsy? Do you have hypertension? Have you ever had TB? What is your HIV status? All that is asked in this in the past medical history. The surgical history is the kinds of surgeries that this patient has had. Have they had dilatation and curettage? Have they had a cesarean section? Appendicectomy? All these might influence their management, so we want to get this history. Drug history, we are just trying to get what drugs the patient is on. Are they on aspirin? You know, they are pregnant, so you will need to check out the drugs that are not supposed to be taken in pregnancy, some drugs that need to be replaced, so drug history is important. And you're also taking a drug history to see if you give them another drug, will it not interact with the drugs that they're already on. Then you need to take a social history as well. Do they take alcohol? Do they smoke? And so on, because where do they actually live? Which area of Lusaka, if you are in Lusaka, which area do they live? And so on. That is important because your area of living has an influence on the kinds of diseases that you have. Then also sometimes you can ask how big their house is, how their finances are at home, if they're able to afford a meal. You're just building on the social history and so on, because when you start treating the patient, they might need to buy a drug and you have no information on affordability and so on. So social history is important. The other thing to remember here is the fact that smoking is quite common right now. People might not smoke a cigarette, a traditional cigarette, but they are smoking shisha, which is also tobacco. So we need to ask about if somebody smokes. We shouldn't assume that the patient is female and they don't smoke, because females are smoking a lot of tobacco as shisha these days. Then we need to take a nutritional history. What do they actually eat at home on a typical day, and so on, because sometimes you have a nutritional anemia and you have somebody who's anemic. You want to know what they're actually eating. And then we also need to take a family history, because some diseases are passed through families. Coagulopathies are passed through families, Van Willebrand disease, things like hypertension, diabetes might have connections. Breast cancer have family connections, so we need to ask about ovarian cancer too. All these things have connections with family, so we need to ask about family history. So after we've taken a history, we need to summarize the history. The way to summarize the history is to give a name of the patient. So you start as, this is Mrs. Nelia Piri. She's para 1, gravida 2, at 30 weeks gestation, who came in with vaginal bleeding at 28 weeks. Then you put in the important positives, like, oh, she has abdominal pain, she has backache, she has PV bleeding, she's draining, and she cannot feel fetal movements. Just that summary gives you an idea of the diagnosis. So you're thinking maybe it's abruptio, because there is no fetal heart and she had rupture of membranes, and sometimes rupture of membranes is a risk factor for abruptio placenta. You can add to the summary that you can add the color of the blood, that it was dark. You can say there's no history of trauma as a like an important negative. All these things, and no history of coagulopathy maybe. So all these things give an idea of what the diagnosis is. And what you are doing in the summary is that you've put together all the information and you're trying to lead the listener to the diagnosis that you are thinking about after going through the whole history. So then you summarize, and then you end there. So this is how we normally take an obstetric history. When you take a gyne history, really the thing that is absent in a gyne history is the history of the present pregnancy. Everything else is really very similar. This template is kind of standard for taking an obstetric or gyne history. So after you've summarized the history, what you now need to do is just give us the most likely diagnosis. What do you think is the most likely diagnosis? So you list it down. Is it placenta abruptio? Then you can also write down the differential diagnosis. So the differential diagnosis would be also other things that are possible. So in the case that we've given as an example, it could be placenta previa, it could be vasa previa because the bleeding started after rupture of membranes, it could be a vasa previa as well. So you put those as your differentials. Maybe you can say maybe a coagulopathy as well as a cause of bleeding. Then when you are investigating the patient and you are examining the patient, you are trying to see which things you find in your examination agree with the diagnosis. So really that's how this everything is linked together. You are not examining patients just examining everything. You have to put everything together, link everything to the differential diagnosis. When you're investigating, you're trying to see, is it abruptio, is it placenta previa, is it a coagulopathy? So all the investigations, your history, your examination are kind of talking to each other. You are not just doing investigations for investigation's sake. You are trying to link it to getting what is really wrong with the patient, and also how are the investigations, how is the examination linked to the story that you've collected from the patient. So thank you so much for listening. We will see you next time.